Yes. Okay. Good. Good morning, everybody. Welcome to the third session of the series on entitled PhD Talks, where we feature the work done or in progress of PhD students. Obviously, we're starting with those here at the business school in Newcastle, but the aim is, of course, to extend that. And if you do have um, someone in mind or yourselves as potential speakers, please let us know. The format it can vary. Today we will have Josefa Enriquez, who is originally from Chile and has been working on her PhD project for the good part of a year and a half, I would say. And the format of today will be of the classic seminar. So she will have a very interesting talk on the challenges for health systems in maintaining and achieving equity and efficiency, asking a pretty, I would say, contemporary relevant question: has the time come for structural reforms? Obviously, this is part of a work that she's done, as part of a publication that she recently got published in the Journal of Risk and Insurance, which is a widely publisher journal. The title of the paper was Designing Feasible and Effective Health Plan Payments in Countries with Data Availability Constraints. It's a technical journal, so the title obviously is for intuitively and immediately extremely interesting for people that have worked in this area before. But obviously, with her experience in the ministry's cabinet in Chile in the past, and being a research fellow in various institutions, including University of Bologna, but also the Center for Public Studies in Chile, very prominent, I would say, research and advocacy, probably. That's the always the think tank. That's the word I was looking for. An institution in Chile, one of the most important in Latin America. She will, of course, draw from those experiences and really broaden and discuss the content of her most recent research to, in fact, um, uh, try and provide some ideas on how to face the current challenges in healthcare systems. Of course, the challenges, we all know them, related to COVID, but those have been dealt as a response to the emergency that also has unveiled structural issues that are now coming all to a point of, I would say, tension, as there are a lot of priorities that countries have in the public domain to deal with. So I think that she, in her abstract, made that very clear when discussing the pressures that healthcare systems are facing and the acuity, some of the trade-off, including the ones between equity and efficiency, raise some of some real tensions in terms of healthcare systems and potential reforms to these issues. So I welcome Josefa. In terms of the management of this session, or housekeeping, in a sense, I would say that um, we will accept questions all along. I welcome you to use the chat functions or the Q&A function. I will monitor them. And if you have something extremely urgent, just put a UQ, urgent question, in capital letters, and I'll try to find a moment to step in and try to raise the question for Josefa to answer. Many thanks again, Josefa. The floor is yours.
Hi, thank you for that great introduction. I will share my screen now in just a second. Okay. So today I will be talking about some of the challenges and also some of the ways that countries could enhance the equity and efficiency in their health systems. And there are many reasons why these might be interests from countries. And here I have some of the challenges that is part of the title of the talk. Some of them, I think probably we've heard of them all, about how costs are really increasing worldwide and governments want to do something about that because there are budget constraints. The population is aging. People are having more chronic conditions, which are also more costly for the health system. There's new technology that's coming up that needs to be funded. And just more recently, what we have all been living through, the COVID pandemic, that has really changed how countries prioritize care so that they can attend to patients with COVID, vaccines, and so on. So all of these are challenges that governments and the health systems are being confronted with. What I wanted to talk about, and then I will touch upon that recent publication that Francesca was saying in part of this talk, as I think it's the cornerstone of a way that countries can balance efficiency and equity, is that really health systems can be designed and can be structured in so many ways. The way insurance works, the way the health systems are financed, and how care is provided to people. And some countries that have been the focus of my study in my PhD have adopted a way that involves public and private actors. And I'll have a series of maps to just give some examples of countries all over the world in different degrees of development that have different types of health systems. In the US, they have many health systems. As I put here, they have the ACA, which is like the Obamacare. They have Medicaid and different types of Medicaid that is oriented for the poor population. Individuals can get insurance for their employment. There's also other forms of Medicare Advantage that is for people that are receiving pensions, traditional Medicare, and so on. So it's a lot of like different health systems going on there. In Chile, which I have pointed in the bottom, we have a very strong like NHS type system, which is mostly funded by taxation and delivered in public hospitals. But then there's also Colombia in Latin America that uses a system more like social health insurance, where there are many insurers that are the ones in charge of providing the coverage for the population and contracting with different providers. And that's also, for example, I have here the case of Ireland, which also is similar to Chile in the sense that it has a very strong like NHS type system, but also has a significant portion of the population that is covered by supplementary and duplicative private health insurance. So both like public and private health insurance interact in Ireland. This is also somewhat the case in Australia with Medicare and private health insurers, which cover for some of the same services as in Medicare, but also they provide additional coverage for other services that are not covered in Medicare. I have here pointed the case of South Africa, that has a part of the population that is covered in this NHS and some others that are covered in private health insurance. So basically what I've tried to exemplify here, that all around the world, there's really a continuum of different ways in structuring the health system, which involves public and private actors. And also in these countries, the delivery of care is also given through different private and public actors. So there's a lot in all of the areas of the health system, there's a lot of public and private involvement. So not only private insurers, so it's not only the government or the state providing care for their population. The issue with these health systems is that sometimes, well, in most of them, there's issues with equity and efficiency, in the sense that some population, for example, the one that has private insurance, has like special benefits and they can skip the waiting times. And that's why I put there's differentials in access for vulnerable groups, people with low income, which generally cannot access private health insurance, or people that are high risk, they're sicker in terms of the population, and that they cannot access the services equally as other parts of the population, even if they need them. And also there's issues with efficiency, as the fact that there's private and public actors makes it for some of the risk to be distributed unevenly among the actors that have the financial burden in the health system. So these are two issues that government may say, well, I really don't want people to be skipping the waiting times, and there's some people that are able to do that, and I also want the system to be more efficient, in that everyone is getting the care that they need, and that the financing is distributed efficiently. So that's why some may want to integrate their health systems into one. So in trying to incorporate in a better way the private actors and the public actors, so that these issues of equity and efficiency don't arise in the health system. And here I have another map, which is the way that typically countries may consider as ways to move forward. So they may think, okay, I will go to have a system such as the United Kingdom, where the NHS covers all the population, and they're the main actors in there, or like the same as in Spain, or in Italy. Or they may choose to go in another route and say, well, I really want my health system as a whole to look more like the Netherlands, which has social health insurance, or like Germany or Switzerland, just to name a few. What I will be concentrating in the following slides is going to be more in how the countries that have the social health insurance system organize their health systems. I will here mention some of the characteristics of what a social health insurance system means, which is the systems that have this type that I say here, managed competition model. Basically, in these countries, the model uses market dynamics such as competition and choice by the individuals in the system to achieve efficiency, while dealing with equity concerns, typically of insurance market, of access, such as I mentioned, and also cream skimming. And I found this quote very revealing, I think, of what this model tries to do. And it says that universal health insurance meant to combine something that markets do better with something that the government does better. So this is what the balance that the managed competition model is trying to strike. The characteristics of the managed competition model basically are the following. The consumers in the market will have a choice between insurers and also among health plans. Everyone can enroll, so there is open enrollment and there is no restrictions based on pre-existing conditions. So everyone in the population needs to be able to have coverage. Basic coverage needs to be accessible to everyone. So the care needs to be timely and within reasonable time, travel time. The premiums or the payments that individuals need to do to have this coverage need to be affordable. And this may be done through many ways, including subsidies to those that cannot pay. And insurers have to offer a defined package of care, so set certain level of services, and will compete in prices, but not in this package, which is equal for everyone. So everyone has access to the same services. There is financing, which is risk adjusted, which means that there needs to be a distribution of funds that is according to risk. So the people that need more funding and need to get more resources, like someone with chronic conditions should be receiving more funds than someone that has really no health issues, because they're relatively not spending very much in the health system. The market needs to be transparent, and people need to be able to compare the products that are available. Also, to be able to discipline the market. So if they say, well, this coverage or this plan is not working for me, they need to be able to really say, oh, this other one is gonna be better. It offers something that I'm missing from the plan that I have. And they need to be able to make those changes by the market being transparent and comparable. And the last point that I put here is that the market can encourage consumers or the individuals, the patients, to be cost conscious, so not to just overspend. So it is possible to have some sort of out-of-pocket payment from the individuals in these systems through the different ways, such as coinsurance or co-payments or deductibles, depending on what the regulators want to establish. I think probably these following slides are the most important in terms of why I am studying this model and why it even matters to be studying a way to organize the health system that is under the managed competition model. And what I argue is that this model is in an advantageous position to balance equity and efficiency, which are usually goals from the regulators, some from the government. They want the system to be equitable and they want it to be efficient, so that the quality is maximized, but also the costs are the lowest that they can be, given the best quality. And they want to achieve the concept of universal health coverage. So they want everyone to have access to the health system. This model is the only one really that uses economic foundations paired with very concrete regulatory tools to integrate the aspects of financing, So how to pay for care, insurance, who is gonna bear the risk for the care, and provision the entities that are gonna deliver the care. The other point that I mentioned here is that healthcare services are private goods in economic terms, with the exception of public health due to all the externalities. And the market is a very good place to provide these services. But the issue is that healthcare markets are a bit different than other traditional markets. And usually healthcare is seen as a right or a moral imperative, as I said there. And this has really justified a largely private intervention, public intervention, sorry, to manage the market and the multiple market failures that may arise. I think this is probably the reason that I personally like the most, and is the fact that usually how health systems have come to be what they are is rooted in historical reasons. Sometimes they have evolved from maybe after a war or some big event, or just through smaller incremental changes that have tried to balance really all the different ways that have kind of more spontaneously been created in the health systems into frameworks that make more sense for the times. And this has usually happened with a combination of public and private stakeholders across all the aspects of the health system. So the managed competition model is able to really deal with how health systems have evolved and the historical aspects of them, and is able to provide really concrete answers to how to get to equity and efficiency and universal health coverage. There is really a lot of work that has been done in this aspect, but really it has focused on some countries such as the Netherlands or Germany or Switzerland, or in the US, for example, also. And what I have been studying is how this model can really be implemented in some countries that differ from the initial settings in many ways. It can be in economic development, but also they do not have this model, and there are proposals, or there has been talks in the countries to really move towards this system. And how would they do it? So I have come up with a revision of some of the kind of checklist that I call of the different elements that countries would need to tick off the list to say, okay, my health system is complying with efficiency and equity in the best way that it can when it has a managed competition model, or it wants to get there. And I have also come up with some conditions or items in that checklist that I believe were not really contained in the literature thus far. And here I put the ones that I thought were not really contained, or to the extent that I believe was relevant, as they're really the cornerstone of the theoretical model. And the first one is the basic package, or the benefit package of services. This is very important because everyone in the population would need to have coverage for the same services, hopefully a very comprehensive list of services, so that the government can be able to ensure a minimum standard of care for everyone. And this is important for equity reasons. The other point is affordable out-of-pocket payments. This is something that is an issue in many countries, where individuals, when they access care, they have to pay a lot out of their pockets, and this can become a financial burden for them and their families. So really, to be able to achieve equity, the regulator or the government needs to be aware that whatever way of out-of-pocket payments they have in the system is not really making the people become bankrupt, or really having to pay a significant amount out of their household budget into healthcare. That would be really detrimental for the system, especially for the poor and the sick. So that would not allow to achieve equity in the system either. Another point that I believe is very relevant for many countries that are not in the stages of full development, or in transition countries, or in development countries, is the issue about conflicts of interest, and really minimizing any sort of capture or bureaucracy by the government. Here we'll just list some of the other preconditions that also stem back from some of the past work in this topic, which are that to be able to have equity and efficiency in the managed competition model, the individuals in the health system need to have free consumer choice of insurer. Consumers need to have information about the plans, about the prices. The market needs to be transparent, so the plans cannot be too complicated, or they can't be 1,000 plans that you really cannot compare between them and know which one is better than the other. The buyers and sellers, being the insurers or providers, but also the individuals, need to bear some of the risks so that they can make cost-conscious decisions, but also they are accountable for the financial decisions. The markets need to be contestable. People need to be able to, the insurers need to be able to enter the market in a way that is free of too many barriers, meaning new actors can enter the system. This will put pressure, for example, on the old actors so that they respond better to consumers and to patients. The insurers need to be able to contract care in the best way that they can. They need to be able to integrate their functions, so they could have to buy, for example, have an integrated arrangement with a hospital, the insurer and the hospital. There needs to be effective competition in competition regulations, so that there's not an insurer that has market power, for example. This would be detrimental for the insurance system. And especially a point that I think is interesting for also countries that are in various degrees of development is that subsidies or payments need to be established so that there are no incentives, or hopefully no incentives for reselection, so that the insurers are not incentivized to just want to receive or give the best care to the healthier population or the young population. And here's where the link goes to the paper at the Journal of Risk and Insurance, where really this sometimes is it's not possible to establish cross subsidies without the incentives for reselection in certain countries, because there is very little data, and data is key to be able to make the right payments for those individuals that are sicker, give them more money, and do that type of financial payments. And in that paper, what we study is ways to alleviate those data issues that could really serve many settings by adapting the data that they have, by using the data on claims to pay and enhance the performance of their health systems. The other aspect that I mentioned here in the preconditions is cross subsidies without opportunities for free riding. So there can't be only some people that are paying into the system and the other ones are not paying anything. That is, well, not fair for one side, but also that makes it really expensive for some of the people that are paying into the system. There also needs to be quality supervision, so there needs to be assurance that the services that are being delivered are of the best quality. And there needs to be access to basic care. So, for example, there needs to be mechanisms so that waiting lists are minimized or not allowed in the system, and people need to be able to reach the services if they live in rural areas and so on. Right. So after revising the checklist of all the things that the government should be aware of when they want to possibly integrate their system into the managed competition model, here what I study is ways in which they could transition from their current state to the model. And I will just briefly mention these three ways that I have typologized. And the first one is they could make the public system and the private system converge into only one regulatory framework and have them compete with one another under the same rules. That is one of the options. They could also say, well, I really don't want to have the private scheme. I want to get rid of it, and I will establish some of the principles of the managed competition model within the public scheme. And then last, they could also say that they want to get rid of the public scheme. This, I think, is probably a less feasible option for many countries, as public schemes are very important and significant, and establish the principles of managed competition within only the private actors that are in the system at that time. I also touch upon two other aspects, and here I will mention one. As before, I talked more about this three ways of converging the insurance and financing, but I don't think we should forget about the way that the provider sector, so the hospitals, the primary care facilities, and emergency care offices should be really neglected and not addressed, because they're fundamental parts of the health system. And there are many issues in the market of providers which should be kept in mind, as I say here, to be able to integrate the system under the managed competition model. And here I am just going to list like the headings of the issues. One of them is contracting restrictions and mandatory financing or subsidies. So it's very common that in health systems where there is public and private involvement, the government will mandatorily be financing some public providers. They will be subsidizing certain public providers. and they may not allow the public system to contract with, for example, private providers. And really, these types of restrictions need to be changed so that there can be real contracting or selective contracting, prudent purchasing by insurers and these new actors in the system that are the ones that are in charge of providing the coverage for the population. It's also really, really important that provider payments and tariffs are taken in mind. I would like to just give one example I think may resonate with many people when they have had a health issue that needs the care from more than one type of doctor, more than one specialty. But it's very usual that doctors just get paid to provide that consultation, but provider payments, for example, can incentivize the integration of care. So for someone that has diabetes that needs different types of doctors to be monitoring their health, there needs to be an incentive for all of those doctors to be talking to one another and to be solving the issue of these diabetic patients in a way that makes the care be coordinated and integrated, and provider payments can be key, for example, to achieve these this issue that I mentioned specifically, among other issues. I would like here to mention some of the challenges that COVID-19 and some of the myriad changes that it has really incentivized, or maybe temporarily, but who knows if these can stick for a longer period in some countries, in regards to the integration of public and private provision. In the countries that I list here, just as an example, Ireland, Australia, and Chile, really the COVID-19 has brought all of the provision, despite it being public or private, into one framework, due to this necessity of really using all of the beds or all of the capacity that was available in the health system. For example, in Chile, a sort of integrated network was established. What this really meant was that private providers had to accept patients that had public insurance, and these providers had to also accept the price, or they were incentivized, let's say, to accept the price that the state would pay them. And they would have to report to the authorities if they had any beds left. So in case there was a public patient that required to be in the hospital due to COVID, and there were no beds in the public system, they could be referred to a private provider. So this shows just an example of how really COVID-19 maybe has pushed the barriers of what's possible in terms of integration. In some countries, I don't think anyone thought this could be possible, but it is. And I think this is also a point in favor and an argument in favor that it is feasible to establish a managed competition type system, and there can be more connection or a better framework that integrates public and private providers for everyone. The last things that I want to mention after talking about insurance and financing and also provision is the role really of the government, that is the governance and the regulation function. And there are several tasks that are related to the governance and the regulation function underlying the preconditions. For example, when I talked about no conflict of interest by the regulator. And there really is no one size fits all approach to governance. There's different institutions that can take different roles, and it really depends on the country. But what I've been studying is some guidelines for countries to also use a sort of checklist and say, am I following these independent of where they choose to really specifically allocate some of the tasks. And some of the principles that I list here are, well, you have to think about all the tasks that you need to allocate and then allocate them all. Because if one of them is not assigned to any specific institution, for example, let's say quality supervision, there's no institution that is in charge of assuring quality, that's not going to be met. Then they need to think about establishing the task in the institution that will know best how to do it. Maybe there is an institution already that is somewhat, for example, in charge of quality, so that may be a good candidate to now assess an enhanced version of this quality assurance. Also avoid the judge, jury, and executioner problems. So you can have an institution that is in charge of conflicting tasks or conflicting issues. The authorities should formulate a clear goal and accountability mechanisms so that the institutions can, we can know if they're achieving or not what they're meant to do. So if it's quality assurance, then there needs to be certain indicators, and we need to be able to see if that institution is really monitoring those indicators and if it's doing really the job that it's supposed to do. And the last one is avoiding political capture and political cycles. So that's just something that they have to keep in mind. Some institutions may be really prone to capture by politicians. Do we want that? Maybe in some it's not going to be that detrimental, but in others that might be a real issue. Just some final thoughts that I had on the topic. What I've been trying to study and trying to understand better is how the managed competition model can be applied to a broader set of countries that are differing the characteristics of the typical countries that have had this model already, to expand really the boundaries of the model due to some of the reasons that I mentioned, because I think it's something very relevant for countries, and it makes sense for countries that have really evolved into these public and private mixes, but now are confronted with these challenges, are confronting with the question of how do I make my health system more equitable and efficient. And also that the tools described well, in the managed competition, well, I don't think they're only bounded to, for example, countries which have mixed financing and provision of services in their health system, but this work can also be used to reassess social health insurance systems, and if they are meeting the equity and efficiency principles, even if they already have the system. And also in some portions of the NHS-like system, there might be competition, and these preconditions would also be relevant in that sector, in that specific sector. Thank you, and hopefully you understood my topic here, and I have created maybe some interest in the managed competition model, and also about thinking about equity and efficiency in health systems.
Okay, thank you, Josefa. let's open to the floor. If there are any questions, how do we do this? Can you stop sharing, Josefa, please?
Yes.
All right. So if there are any questions, please jump in. I received this question. So this is from, we don't know from who.
I put it in, Francesco.
I saw that. Yeah. There are a lot of preconditions identified to achieve the model of managed competition. Which ones do you think will be more difficult for countries to fulfill?
Thank you, Stephanie. Yes, indeed, there are a lot of preconditions, and I've heard from some people in governments and politicians, well, the list is so long, it's so difficult that maybe we don't do anything, we don't proceed with any change. But I think we have to start somewhere, and I think maybe the most difficult one is the one we should address first and try to achieve some consensus, and one that I think can be very challenging due to political reasons probably, and just interest in general, would be being able to establish subsidies to cover for care in private entities, as the model tries to integrate, right, public and private entities. That may be a very big issue, but it's something very necessary that irrespective of the type of insurer that enrolls you, you can receive, if you cannot pay, you can receive subsidies to be able to afford the cost of that coverage. If you're low income, for example, or if you're very high risk, and otherwise in a free market, probably your insurance would be very, very expensive. So to be able to cover those two types of population, subsidies are very important, but there might be a lot of issues specifically in some political sectors that will not want to provide subsidies if you're attending private providers, or if you have private coverage. That might be one of my judgment, one of the most difficult things to achieve.
Okay, are there other questions? You can also unmute, maybe no, you can't do that. So you need to write, that's the only way. Maybe I'll ask something. So maybe this is related to the question. Isn't it maybe one of the most important, well, one of the most important, well, the question, it's interesting about the preconditions, and which is one to fulfill. Obviously, if you look at the evidence of countries that have done, that have tried to introduce this model, the most difficult part of the reforms, although they're all pretty demanding, is to operate the part of that model that has to do with the provision side of services rather than the financing, right? So if you look at the Dutch system, for example, they've done a lot, everything almost to perfection when it comes to the regulatory framework of the insurance sector, the package definition, the subsidies, anyway, so that side of the equation of the model regulated competition or managed competition seems to have been dealt with in the most advanced systems. I agree with you that for those that need to introduce and integrate a model that has multi-tiers like the Australian or the Chilean system and so on. And that is probably historically been the way to go, the place where we start from, so the insurance financing side of things. But the reality of it is that once that's done, the second part of that model, so the competition, the contestability of provision of care services, and the tension between vertical integration versus competition, in fact, in service procedure and so on, seems to be most challenging. Obviously, the reason there, it's of course you're facing a very powerful association, so the doctors of course want to protect the market and so on. But I would probably try to think hard about that set of preconditions as the most difficult to fulfill, not only for political reasons but also practical. So it's more a comment perhaps than a question. Now, and I think I say that also in relation to the special issue you're driving at the moment, Josefa, that you haven't really talked about, so you might do that more in detail. But before there is this question, has COVID-19 created the conditions for Australia to try a version of managed competition? What needs to happen now for Australia to move to such a model in a sustained way?
So I think to address that question, there has been several proposals in Australia to establish a model of managed competition. And I believe there are many elements, for example, that are advanced in the system currently that are not as advanced in some other countries which have also considered the model. And specifically, for example, as I was talking about subsidies, in Australia, there are already subsidies for private insurers. So I think that if that is already there, that is something good. That's progress being made. There's already some form of cross subsidies in the private insurers with the risk equalization model. In Medicare, there's already some form of a basic package that could be extended for the private insurers. So there are many elements that if we think about how the Australian health system works, could be used as the first stone to establish the model. So I don't think it would be that impossible, as there's so many elements that we could use as a baseline. I think COVID-19 has definitely blurred the line between the public and private providers in Australia as in elsewhere. And I think that's an interesting phenomenon to really understand, or to see how this could move forward in terms of the managed competition model. There is a way that we could potentially integrate also the provision sector, not only the insurers or the financing in the Australian health system.
Okay, that's interesting. Maybe there is space for one more question. All right, no, if not, I would like to thank you, Josefa, of course, for this presentation. Stephanie will certainly make sure that this is going to be distributed as widely as we can. A very interesting topic indeed. We look forward to see the special issue that I think is the last thing that I would like you to present and discuss a little bit more in detail. for people to keep an eye on this space, Josefa, so that you can conclude with that. Thank you also, everyone. And once Josefa finishes, we say goodbye until next time.
Okay, so this work and this thoughts are part of a special issue that has been accepted and that we're currently working on for the Journal of Health Economics, Policy and Law, where we have some conceptual work, that is this one, and some other papers, but also we have some very interesting country applications where countries from different parts of the globe and really different advances in terms of economic development have thought about the managed competition model in their countries and have written about it and really developed some of the issues they see or some of the ways forwards that could open path to the managed competition model. So we expect that to be on its way during this year, and I think the papers are coming along very well. We have countries such as Colombia, South Africa, Ireland, Australia, the US, which I think provide a very nice diverse group of countries that there's not much in terms of the managed competition model out there. So I think it will be really interesting to have a look at how all those papers come along.
Excellent. Thank you so much. We encourage you, of course, to follow us on our website, Value in Health Economics Price Group, and also on social media. And I wish you a good day, everybody. And thanks for joining us.